a parasitic infection, schistoplasmosis, and you can see that it has a turtle back sonographic feature. So they saw the calcifications on X-ray and sent her to ultrasound, and found out she had a parasite. HIV and AIDS. HIV is the first stage of AIDS. You have to have HIV before you can acquire AIDS. The different stages of the AIDS can develop disease processes inside of the body, because the first stage is going to be where it develops pneumonia, and from pneumonia, that bacteria or that pneumocystic, whatever it's called, it can travel to the liver, the spleen, the pancreas, the lymph nodes, the thyroid, and the other organs. So if it goes into our liver, then we can see that the liver will have a starry sky appearance, much like hepatitis will have. One thing about HIV and AIDS, they will have hyperocholic kidneys for unknown reasons, because they're going to develop, the HIV also attacks the kidneys, okay? Kaposi sarcoma is what they develop on their skin, where it looks like they have kind of like leprosy. But those Kaposi's, the sarcomas, can also infect the liver. They can cause the liver to look like it has fatty infiltration. The liver gets big. It looks like it has hepatitis by the starry sky. It can develop, your body can develop non-Hodgkin's lymphoma. It can have a fungus in it. That fungus is called candidus. And it's some pretty wicked stuff. Okay? So here you have the starry sky appearance on someone with AIDS. So this patient has hepatomegaly, and you can see that we have this heterogeneous mass that upon biopsy, that's the only way that we can define that, is ended up being a Kaposi sarcoma. We can't confuse an enlarged liver hepatomegaly with Rydell's lobe. You can see that this liver is it's heterogeneous. It's not homogeneous. If it was Rydell's lobe, it would be homogeneous. Hepatic candidus. You looking for Piper? Okay. Candidus is also a liver complication of HIV, and it happens with immunocompromised patients. Like immunocompromised patients, that can be someone with RA, that could be someone with mononucleosis. Anytime that you are immunocompromised, what's another one that they could, something Barr, Epstein-Barr. Epstein-Barr is also an immunocompromised disease that can cause hepatomegaly. When we think we see a fungus, our discerning sign is a wheal within a wheal. outer wheel is fibrosis, and the inner wheel is a necrosis. So everybody understand the differences between fibrosis and necrosis.
Necrosis is dying of the tissue, or death of the tissue. Is it possible? Is that true?
Correct. Fibrosis is when it gets hard.
Right.
And necrosis is when it's dying off.
Mm-hmm.
Very good. So here we have micro abscesses due to a fungal infection, and that fungal infection is called candidus. And you can see that the liver is heterogeneous, and you do have, like, see here is a wheel on wheel, here's a wheel on wheel, here's a wheel on wheel. See how it's hyperechoic and then isoechoic on the inside. Those patients present with fever. It's hard for us to discern whether it's a metastatic disease because it looks the same thing, and so we would just say that this is a heterogeneous liver in an immunocompromised patient, and the patient has had a history of chemotherapy. So we're going to, on our diagnosis sheet, we're going to put as much information on that sheet as what we can. Hemangiomas. Hemangiomas are the most common benign tumor of the liver. These lesions are not neoplasms. They are a large network of blood-filled vascular spaces that are lined with endothelium. They're 5 times more common in women. They increase in frequency with age. They are asymptomatic, and they're usually found incidentally. Okay, remember when we were teaching you to get that outer edge? You take the midclavicular, and then you go back to midline, and you angle out to get the capsule of the liver. This is the reason why we teach you that image.
Is that lateral liver?
Love to live along that capsule.
Okay. Is that the lateral position of the liver, or the right liver?
It's the lateral position of the liver. That's why this, and why you're taking that picture is you're looking for hemangiomas, because they love living along that capsule. So they can have several different appearances. They can be solitary, or you can have many of them. Because the patient is asymptomatic, they're usually going to be incidental finding. They're usually going to be less than 3 centimeters. But you can have ones that are going to be larger, and those are called giant hemangiomas. And they're almost always located in the right lobe of the liver, subcapsular along the periphery of the liver. Okay? Sonography is more reliable than CT because we can see smaller lesions than CT can. Anytime you see those lesions, you have to measure it with and without measurements and with and without color. If you don't see color, you're going to use power color, and you're usually not going to see color because the flow is too slow to be visualized. So here's a hemangioma, and here is a hemangioma. Large one, and then here's one, and then here's one. Here's one by itself. Here's a hemangioma. here's a hemangioma, and here's a hemangioma. You are usually not going to see blood flow in these. Even though it's a vascular tumor, you're not going to see flow within the hemangioma. They're usually always going to be hyperechoic. Anybody seen one?
I think so.
Focal nodular hyperplasia. Okay, focal nodular hyperplasia. It's the second most common benign liver mass. What happens is it's contained normal hepatocytes, including your Kupffer cells. Remember, the Kupffer cells are your active phagocytic cells of the liver. It does affect your bile ducts, and it can make your liver fibrotic. Okay? The arterial hepatic artery supplies the focal nodular hyperplasia with arterial flow, and that drains into the hepatic veins. It doesn't affect the normal venous branch of the liver. They do affect all ages. They're rare in children, but it's mostly in women and with childbearing ages, as if we don't have enough already, right?
Right.
There is a tie to oral contraceptives. They're usually asymptomatic unless they hemorrhage. And they're usually going to be an isoechoic lesion that's going to be difficult to identify to liver parenchyma because it is isoechoic. But it can have a multitude of echo textures, including hypoechoic, hyperechoic, and isoechoic. It's not going to be encapsulated. It's not going to look like it has a rim around it, but it will have a scar in the middle of it because the connective tissue has turned fibrotic. It will be thin walls, and it may not appear on some images, so it's really hard for us to see. They usually range around 5 centimeters, but they can get as big as 20 centimeters. And our job as sonographers is that we have to find the feeding vessel, just like if we see a lymph node inside of we have to find the feed. We can inject, this is a nuclear medicine scan where they call it TC99, and they will show up on nuclear medicine. If it's an adenoma, it will not. But if it's a focal nodular hyperplasia, then it will. And of course, if you have contrast enhanced imaging, I don't know of anybody in Houston that does have that, but what do I know? Okay. So this person came in to look for gallstones. And what they found was this gigantic mass, and it's compressing on the IVC. So we have to be very careful with that we can do that measurement. Of course, you're always going to measure the longest dimension first. They say that if it's wider than tall, that's a good sign, but if it's taller than wide, that's never a good sign. An adenoma. An adenoma it doesn't affect the bile ducts or the Kupffer cells. It is a true hepatic encapsulated neoplasm, so it will look like it has a halo around it. But it can press on the bile ducts, causing bile stasis. It can bleed, and it can necrose on its own. And again, it's an uncommon mass, but it is affected to women in childbearing age. It is associated with birth control pills. It can also occur in men that take steroids, or in people that have type 1 glycogen storage disease, which is called Van Ginkel's disease.
So it is a benign tumor, correct?
It is a benign tumor.
Okay.
Lesions can shrink or disappear after hormones. And now remember, it is mostly in women that have on birth control pills. So if they stop their birth control pills, then the lesion can shrink or disappear. It's usually going to be an incidental finding because the patient is usually going to be asymptomatic, but it can be palpable. It can cause right upper quadrant epigastric pain, the same as what you have with gallstones. Liver cell adenomas are usually going to be removed due to possible rupture or becoming malignant. Even though they are they're not malignant, they can become malignant. They will appear to be encapsulated. There'll be a hyperechoic mass with a hypoechoic halo. They can be isoechoic, but we're going to look for the halo that is around them. If the tumor hemorrhages, of course, the appearance will appear to be different according to the age of those red blood cells. So here we have an adenoma. You can see that it has a rim around it. It has a pseudo-tumor appearance. It's hypoechoic with a hyperechoic center. Here it is with color, and you will see a rim of vascularity with a hyperechoic center.
So you have to turn on the color to see the halo, right?
Yeah, see how it has a halo? But when you put color on it, it's all vascular. That's called a liver cell adenoma. Here's another liver cell adenoma. And you can, it doesn't have the rim around it because it has already ruptured.
Oh, that's why.
A lipoma. A lipoma is just a fatty tumor. These individuals are usually going to be asymptomatic. You can have angiomyolipomas, blood vessel, muscle, fat in patients that have tubular sclerosis. Tubular sclerosis is a genetic disorder, and we can confirm a lipoma with CT better than we can with ultrasound. So when we find something on ultrasound, if they come to ultrasound first, we usually send them to CT. If they find something in CT, they usually come to ultrasound. They like to make that diagnosis with 2 imaging modalities. Okay, so it's up to you as a sonographer if they come to you first to look at the CT and find out exactly where it is that you need to look, and they will do the same in CT that we do in ultrasound. So if we see a lipoma, it's going to be highly echogenic. So it's going to be hyperechoic. You will develop artifacts because of the speed error. So if you have that, we're going to, because of the speed error, it's going to look like it's deeper in the body than it is. Because of physics. Because no other liver mass can cause this speed error artifact, and so that's our definitive diagnosis. Here is a lipoma or a angiomyolipoma. It's an echogenic mass. It almost looks a lot like a hemangioma. A hemangioma, though, it has a smoother border on it.
Is that an appearance of a core biopsy taking place in there?
Is this will they do a core biopsy? That I don't know.
I was looking at the echogenic line going through the mass. Do you see that?
Yes, I do.
Okay, I was just wondering if that was like they was doing a biopsy there.
Yeah, I don't know. I think what we're looking at is this is Morrison's pouch.
Oh, I see what that is. That is the border of the kidney.
Yeah, it's the border of the kidney, and here's the kidney. But because the speed error, see the speed error, where it throws it deeper into the body than what it is. Okay.
The speed of sound is slower in fat.
Say that again.
Yeah.
Its speed of sound is slower in fat.
Yes.
So that's why it gives that error.
Okay, good.
Okay, which benign liver neoplasm is associated with using oral contraceptives?
FNH.
Focal nodular?
Focal nodular hyperplasia.
Oh, okay.
Which benign liver neoplasm typically presents with a speed error artifact?
Lipoma.
A lipoma. Which benign liver neoplasm histology includes Kupffer cells that accumulate injected with nuclei?
Liver cell adenoma?
Liver cell adenoma. What are they going to do to an adenoma? They're going to surgically remove it because it can turn malignant.
Is that the second most common, right?
It is the second most common.
Right.
Okay, malignant neoplasms. Primary liver tumors may originate from hepatocytes or bile duct epithelium. Okay? It is sonography is used a lot for liver tumors. If you have contrast enhanced ultrasound, it will expedite the diagnosis. Often patients has a malignancy with unexpected findings of liver mets. What that means. So the number one mass is called hepatocellular carcinoma.
Roy Marie.
It is a primary malignant liver tumor, and it develops in the hepatocytes. that hepatocellular carcinoma. Next to that, you have cholangiocarcinoma. That means that it has developed in the bile ducts or the gallbladder. Cholangiocarcinoma. Hepatocellular carcinoma is higher in patients with hepatitis B and hepatitis C. I don't know what neoplastic I don't know what that NASH. I told myself I was going to look that up, but I didn't. So a patient with cirrhosis can also develop hepatocellular carcinoma. It also happens because of parasitic liver infections. Patients with hemochromatosis and metabolic glycogen storage disease and cirrhosis have a higher incidence of developing hepatocellular carcinoma.
That NASH is non-alcoholic fatty liver disease of some sort.
Thank you.
Steatohepatitis.
Yeah.
Non-alcoholic.
Yes.
Yes, non-alcoholic.
In the United States, the majority of HCCs, thanks for looking that up, develop from pre-existing cirrhosis. It's usually unusual before the age of 40, and it's more common in the sixth decade of life. You have a higher incidence in blacks than whites. Men are 3 times more likely than women. And men, liver cancer is the 10th most cause of cancer due to death. And in women, you have a 5-year survival rate. It interferes with your liver function. You'll have biliary obstruction, ascites, jaundice, portal vein hypertension, portal hypertension, and metabolic disorders. What's our sonographic measurement for portal hypertension?
Greater than 3 centimeters.
1.3 centimeter.
1.3.
Centimeter.
1.3 centimeters. Okay. So when you make that measurement, guys, be very, very careful that you're not giving them a diagnosis that they don't have. So the LFTs that will be elevated will be ALP, AST, ALT, and AFP is the most significant because AFP, a man should never have AFP, right?
Yeah.
AFP is put out by the fetus to telling our body that we are pregnant.
Mm.
So, or if you have someone that's in their 60s, you know they're not pregnant, but they have an elevation of AFP, then we know we have an HCC that we need to look for.
Yeah, there are some cancers that give off that, the elevated AFP or HCG.
Yes, and HCC is one of them.
Mm-hmm.
I think so. There's some. The only one that rings my bell right now is HCC, but there's other ones that do also. Okay, so if I have HCC, it can metastasize. It can metastasize to the heart, the lungs, the brain, the kidney, the adrenal gland, the spleen, and then the bone. Clinical symptoms are weight loss, nausea, vomiting, pain, pruritus. Do y'all remember what this is? You get it because of this.
Is yellow eye?
Pruritus. You get it because your skin turns yellow and then
Yes.
it's itchy.
Itchy. Oh.
People with jaundice usually always have pruritus. So you have splenomegaly, a palpable mass, hepatomegaly, and ascites. You'll have a diagnosis where on the medical history you'll have an increase of AFP, And the only way for us to make that diagnosis is if we go through a biopsy.
Mhm.
So sonographically, it can be variable. It can be focal, where it's limited into one area. Oops, sorry. You can be, it could be multiples because it applies in different areas. It can be diffuse. It infiltrates the whole liver, making it heterogeneous. If I have cirrhosis, the liver is hyperechoic, and so the HCC will usually be hypoechoic. It will look, it will be scattered. If you can have a large dominant mass, you can have a scattered satellite lesions where you have the main one and then it's already started to metastasize. They could be hypoechoic, hyperechoic, homogeneous, heterogeneous, localized, or diffuse. That describes every vocabulary word we've learned, right?
Mhm.
Yes.
So if we put color on it, which is what we're going to do, we're going to measure it with and without, and we're going to use color. It will be very chaotic, and you will have many echo, what did they call it, mosaic.
Mhm.
Sometimes you can have cystic areas with calcifications. It can invade the portal system. It can invade the hepatic veins. If it invades the hepatic veins, what do we have?
Hepatic obstruction outflow.
It was hyper. No.
Budd-Chiari.
Bronchiari.
Yeah, Budd-Chiari. Call your dad. Tumor thrombosis tends to dilate the vein more than gland thrombus. Remember, if you have hepatic vein thrombus, then you have Budd-Chiari. So not only do you have HCC, you also have Budd-Chiari. When we see the disease process, we're going to localize it, we're going to measure it, and then we're going to tell the doctor specifically what it looks like. Is it focal? Is it multiple? Is it diffuse? What section of the liver is going to be involved? Is it invading the intrahepatic vessels? Is it invading the IVC? Is it invading the portal system? Is it compressing the bile ducts? Is it causing localized dilatation? Do we have the barrel sign inside of the liver? Because if we have the barrel sign, we have intrahepatic dilatation of the ducts from the cystic ducts. Now, what they can do with hepatocellular carcinoma, they can do they can go in and they can do a transcatheter arterial chemoembolization. They can go in and inject it with ethanol. They can do radiofrequency ablation. They can do cryoablation, or they can do a liver transplant. They can also just go in and take out that section of the liver. Abnormal LFTs, a normal AFP, a hyperechoic mass, later biopsies and confirmed is HCC with A. So, and it's heterogeneous. See how it looks like it has cystic and it looks like it has solid components too? Here we have a 62-year-old woman. She has elevated AFPs. She has elevated LFTs She has a hypoechoic mass. It looks like it has a halo around it. And once they did a biopsy, it was also considered to be an HCC. And so look at the differences between the two. One of the things that we look at, because it has a hypoechoic area, we're going to automatically think that it's an adenoma. Here's ascites. Okay. So here we have ascites and we have a pleural effusion. See the difference between the two?
Yeah. Position.
Here's a pleural effusion and here is ascites. A pleural effusion because we have that little V, so we know it's on the thorax side, and we have ascites, which is on the side of the liver. Here we have a hypoechoic mass that ended up being HCC. Here we have thrombus inside the main portal vein. On biopsy, it showed that we had an HCC. And look at the portal vein. Isn't it supposed to be
Monophasic.
It looks like it's arterial flow inside of the main portal vein, because the main portal vein should be it shouldn't have these peaks. Okay, which clinical symptoms is associated with HCC?
Splenomegaly.
Yeah, the only one there is splenomegaly. Now, when we find HCC, we want to make sure that we look at the aorta, because we are looking for lymphadenopathy. You're seniors now, so you're not just taking pictures, you're actually looking for pathology. You have weight loss, not weight gain. You have right upper quadrant pain, not left lower quadrant pain. Lymphadenopathy, that's not a clinical symptom. Which lab test is HCC?
AFP.
AFP. Let's talk about hemangiosarcomas or angiosarcomas. It's rare, extremely aggressive malignant tumor that begins in the liver blood vessels. It is a strong association with arsenic, polyvinyl chloride, so it comes from environmental. It happens to the 60 to 80-year-olds with rapid metastasis, and it metastasizes to the lung, the spleen, the lymph nodes, bone marrow, thyroid, and the peritoneal cavity. And it depends on when we find it, on how it presents. So after the lymph node, the liver is the most common site for metastasizing. And the most common is HCC. It 80 to 20 times more common than HCC. It metastasizes to the gallbladder, colon, stomach, pancreas, kidney, ovaries, breast, and lung. Symptoms include hepatomegaly, jaundice, weight loss, abdominal swelling. But the patient can also be asymptomatic depending on what stage of the development the sarcomas are. So what they will try to do is they will resect that area of the liver that has the metastasis in it. It can look at several different, our main thing that we look for are bullseye appearances. Because it can be hypo, hyper, iso, anechoic, but our defining definitive sonographic sign is a bullseye or a target appearance. So if we find a hyperechoic lesion, the primary came from the colon or renal cell carcinoma. If it mostly looks cystic, it comes from leiomyosarcomas, or it comes from the mucinous ovarian cancer. If it's hypoechoic, it usually comes from lymphoma. And if it's a bullseye, it usually comes from liver cancer. So if we did contrast enhanced ultrasound, it will help categorize what we have. But we always try to locate, measure, and characterize and describe what the lesion looks like. If we have a female, we are usually going to look for large pelvic masses. And it's up to us to tell if it's an obstructive or it's a non-obstructive jaundice. So here we have hepatic metastasis. The patient had a pancreatic head cancer and it metastasized to the liver. And B, we have the bullseye lesion. See, it's hypoechoic with a hyperechoic center, and that came from lung. This patient had lymphoma. Here on the left, the patient on the right had renal cell carcinoma. Okay, which statement is true regarding hepatic metastasis?
Amen.
I would say it would be D.
Yeah.
Because alpha-fetoprotein comes with HCC, not if you have metastasis to the liver.
Right.
Question.
Yes.
So it's safe to say that this disease originates somewhere else and metastasizes to the liver?
Correct.
Mm.
Correct. For HCC, it will be AFP.
Mm.
Okay? For HCC, it will be AFP. Okay, contrast enhanced ultrasound. I know nothing about it. I don't know anybody that does it. It came after my time.
With contrast enhanced ultrasound, is the contrast been placed inside the vessel or just directly in the tissue?
Yeah, they inject it into the bloodstream.
Yes, okay. Yes.
And with real time, it almost looks like an angiogram where you can document the blood flow into the lesion.
Mm-hmm.
Is anybody doing contrast enhanced ultrasound for your research paper? No?
No.
No.
Okay, since I haven't read this, we're going to stop here. And I'll see. Is today Wednesday?
Yes.
Okay. So I will see y'all tomorrow. Any questions over what we've talked about today?
Not yet.
Yes, Ms. Shepherd. So on the last question that we had regarding the metastasis, which lab are we saying?
AFP
AFP for
is
HCC.
only for HCC.
Got it.
But if I have metastasis to the liver, I'm going to have abnormal AFP. I mean, I'm going to have abnormal LFTs because my liver is not functioning the way that it should.
Correct. Okay.
But if I have hepatocellular carcinoma, I have an increase of AFP.
So the AFP deals with metastatic.
No,
with the HCC.
only with HCC.
Okay.
Let me look and see. Let's go back and look. I don't want to make okay.
Not elevated, yeah.
AFP is typically not elevated with liver mets.
Okay, gotcha.
AFP is for HCC.
You see, gotcha.
So almost all of the disease processes that we've talked about have almost the same appearance. Now we learned today that a lipoma causes the speed artifact.
Mm-hmm.
It's the only one.
Mm-hmm.
An adenoma has a halo around it.
Mm-hmm.
A focal nodular hyperplasia and a hemangioma look almost exactly the same. The only difference is focal nodular hyperplasia is not always hyperechoic. But if you have a hemangioma, we mainly see those against the capsule because that's where they like to live. Sarcoma is malignant. HCC is malignant. What else did we talk about today?
LCA. Liver cell adenoma.
An adenoma, they usually will resect that, or they will treat that because it has a tendency to be malignant.
Ms. Shepherd, when we are doing our notes, are we more so saying like heterogeneous or homogeneous? Are we more so just describing what we see?
That's the only thing we do. We don't guess what it is. Some facilities will make you do a, my brain just went blank. If it's not this, it's this.
Mm-hmm.
But we, as sonographers, only describe our masses. We don't make a diagnosis. That's why the doctors make the big bucks, not us. We just describe it.
So during the board exam, as we're preparing for board, the questions that's been asked, are they asking